Assalamu alaikum friends. Welcome to my YouTube channel Orthopedics Made Easy. So just to revise why my videos are important because they are very precise and exam oriented, and I'm trying to present it in interesting and simple way. So and in each video I'm just covering one topic related to your exam. So if you go through each topic, it will be easy for you to prepare for your theory exam, practical, and also even for your interest exam. So with this introduction, let's start today's topic. So this is one of the common fracture you will get in your theory exam. So what is it? So here the history goes like this. There is a 30-year-old male patient here. So here, if you see, there is 30-year-old male patient and he has road traffic accident and he fell on the right side shoulder. So after the injury, he noticed swelling and pain along the shoulder joint, along the collarbone. There is no other injuries. And on asking the history, there is no any respiratory disorder, distress, or there is no distal neurovascular deficit. These two are very important in relation with this fracture. Okay, so with this history, the patient having shoulder injury with the collarbone swelling, if you see like this, there is a swelling like this here. So it is a clavicle fracture. Okay, so today our topic is clavicle fracture. So clavicle fracture, it may either fracture in middle one third or medial one third, middle one third, or lateral one third. But most common is middle one third. Middle one third is the most common site for the clavicle fracture. So here, if you see middle third region is the most common cause of clavicle site of the clavicle fracture because this is relatively weak in location, relatively weak in strength. So this location is relatively weak. So why it is weak? One is nutrient artery enters here. If you see, the nutrient artery enters along this area. Then second is it change shape from cylindrical to flat. So on the medial aspect, it is cylindrical. Here it is flat. So it changes its shape over the middle third region. The third thing is there is no muscle attachment on this area. If you see, we have sternomastoid attached here and the other muscles and deltoid attached on the lateral side. So this area, there is devoid of muscles. So that's the reason it is weak. So these are, and it is thin and narrowest. So the reason for the fracture occurring in the clavicle commonly over the middle third region is it's a relatively weak zone secondary to presence of nutrient artery foramen, change in the shape from cylindrical to flat, and there is no muscle attachment, and it is thin and narrowest part of the clavicle. So these are the reason. That's why the clavicle in the middle third region is weaker. So before knowing the going to the fracture, we need to know the forces acting on the clavicle. So what are the forces? So if you see here, we have sternocleidomastoid muscle attached on the medial side, which pulls the clavicle on the medial side up. Here is the weight of the patient's body going down. So here is the weight. Here is the sternomastoid. So these are two opposite directions. So if there is a fracture over this area, this fragment will pull up, this fragment will go down. This is the direction of forces. And one more thing you need to remember is there are two ligaments which are holding the clavicle. So these are starting from coracoid process going to clavicle, coracoclavicular ligament. These are conoid and trapezoid. And we have very close neurovascular bundle. So we have very close neurovascular bundle or brachial plexus here. And we have nutrient artery, which is making it little weak. This is the direction of the forces. And to remember is, this is coracoid process, coracoclavicular ligament, conoid and trapezoid part. With this anatomy and the reason for the fracture, we move on to the fracture per se. So what is the mechanism of injury? There are two types, either direct injury or direct blow to the collarbone, or injury indirectly due to the fall on hand on the shoulder. If you see this, this is one mechanism where directly there is hit over the clavicle. Or second thing is indirect by fall on the shoulder or fall on the outstretched hand. This is the direct or indirect mechanism of injury for the clavicle fracture. Then what is the displacement? Just now we have read that there are two forces, opposite forces, which are acting on the clavicle. On the medial side is sternomastoid, which is pulling the clavicle up. The other side is the weight of the limb, which is pulling the clavicle down. So if there is a fracture here, the medial end will move up, the lateral end will move it down. So this is how this happens. If you see that this is X-ray of the clavicle fracture. This is a middle third clavicle fracture, whereas medial end is pulled up and the lateral end is displaced down due to the weight of the limb. This is the direction of the displacement. So what is the presentation? Patient has history of trauma, either direct or indirect injury. And on examination, there is swelling and the fracture sign, that is crepitus will be there, abnormal mobility will be there, swelling will be there, tenderness will be there, and on the collarbone. So this is the presentation. So what are the things you need to check? So in the history, I have described about the lung injury, I mean, the presence of tachypnea or dyspnea and presence of neurovascularity. So because we have very close relation to the, here we'll be having the neurovascular bundle and the lungs parenchyma will be going like this. So there is every chance that when there is a clavicle fracture, there is lung parenchymal injury or injury to the neurovascular bundle. So always you need to examine. And it's a subcutaneous bone, so it get lifted up. So it may damage the skin also. So always check the skin condition. If there is any tethering or kinking of the skin, then check for the distal neurovascularity. You need to check for the brachial plexus. You need to check for the venous condition. You need to check for the any arterial obstruction. So all nerve, vein, and artery you need to examine distally. And the important thing here is the lung parenchyma and the lung pleura is just behind it. So if there is a very massive damage or very massive forces, the force may be transmitted to the pleura. Also, there may be a breach in the pleura. So patient may develop subcutaneous or emphysema, or patient may have proper emphysema. So these all the things always you need to look when you have a patient with clavicle fracture. How will you diagnose? So we do diagnose clavicle fracture by X-ray. So it's most of the time there is no need of further investigation. If you see the X-ray, you can find the clavicle fracture. So is very visible on X-ray. So here I just want to remind you, or will just revise what are the birth fractures. So we have the fracture during the course of delivery. By the normal delivery, the baby is at risk of developing some fractures. So among that, clavicle fracture is most common, followed by humerus fracture and followed by femur fracture. So clavicle is most common fracture present as a birth injury. This is common PGB task. Birth injury, you have clavicle fracture as a common fracture. It is this is one thing you need to remember. At the time of birth, you have clavicle fracture. In the last class, we have read what are the most common childhood fracture. Childhood means in the neonatal, not in the birth, but after the birth, maybe like in infancy or in cases of adolescence. So the most common is distal radius. Then distal radius, it is followed by हैंड इंजुरी. मैं लास्ट टाइम भी बोला था कि जैसो हर घर में कोई ना कोई छोटा बच्चा रहता जो अपने बचपन में या तो दरवाजे में उंगली लाया हुआ रहता या नहीं तो फिंगर साइकिल के चेन में या साइकिल के स्पाइक्स में. So distal radius is most common, followed by hand injury, followed by other fractures. Whereas at the time of birth, clavicle is most common cause of common fracture presentation. Whereas in adult also, clavicle is common fracture. So just to go through the pediatric fracture PowerPoint. In that, I have clearly described the common fractures in birth, after the birth injury, common fracture in the childhood, and common fractures in the adult. We'll move on to next slide. So when we have diagnosed the clavicle fracture, we need to plan treatment. So what are the modalities of treatment? We can go do conservative treatment. How will you do conservative treatment? We can just give arm sling, or we can apply figure of 8 bandage. Figure of 8 bandage starts from here and goes like this and allow down the axilla. Sorry, I couldn't get the figures, but I should. It's a we put a figure of 8 bandage to treat conservatively. And if you feel like patient needs surgery, we do go for open reduction and plate or intramedullary. If you see here, the fractured clavicle fixed by plate, here the fractured clavicle fixed by intramedullary implant. So most of the time, clavicle fractures are managed conservative way, unless there is a indication. So indication, it is out of your scope, but if you want to remember the indication for open reduction. open reduction indications are: first, patient is having neurovascular injury, or patient is having open fracture. The fracture is open and its skin is damaged, or if patient is having bilateral clavicle fracture. So these are the few indications for open reduction. Otherwise, clavicle fracture in almost children, adult patient is, unless not sportive or he who throw involved in throwing ball activities, something like that, you can manage it conservatively. What are the complications of clavicle fracture? It may land up in non-union, because as we told, there are two forces: the weight of the limb pulling the lateral end of the clavicle down, whereas the sternomastoid on the medial side pulling the medial part of the clavicle up. So there is high risk of non-union, and this also results in malunion sometimes. So if there is a malunion, there is a cosmetic discomfort. Then if patient is having a high velocity injury, patient will have neurovascular deficit. If you see here, this is a patient with a clavicle fracture managed conservatively. Here is the surgery. So you need to decide yourself whether the patient, this is more acceptable or this is more acceptable. The scar over the clavicle is acceptable, or just a lump over the chest wall or the collarbone is acceptable. So most of the patient know they won't prefer a scar over the clavicle, because it is very superficial and exposed part of the body. So they prefer to go for conservative treatment. So unless there is a strong indication to go for surgery, better manage all these cases conservatively, because the result of non-union and malunion, patient do well without any much difficulty in daily activity or in routine activities. So it can be managed conservatively. And if you are doing surgery, there is risk of infection, because it is just subcutaneous bone and there is no muscle coverage. So whatever implant you are putting, it is just under the skin, so it will cause some hardware related problem. Then cosmesis extol, the scar over the collarbone, it's very disfiguring to the patient. And sometimes when you are dissecting, you may damage the supraclavicular nerve also, because the nerve goes from here like this. So if any injury to this nerve, it causes numbness over this area. So these are all complication of surgery. So many surgeons, they prefer managing this conservatively. Many the patients also, they prefer to be managed conservatively on giving a proper explanation regarding the course of the disease and the risk of non-union, and there is no much problem with non-union. Then we'll move on to next slide. So these are the two conditions I want all undergraduates or MBBS graduates need to know. One is cleidocranial dysostosis. This condition is described in your practical DAS also. So what is this condition? There is a problem with intramembranous ossification. In the fracture healing PowerPoint presentation, we have learned about intramembranous and endochondral ossification. Intramembranous is the mesenchymal cells directly getting converted into bones, whereas endochondral ossification is we have learned two things. One is intramembranous ossification, one is endochondral ossification. Intramembranous, here the mesenchymal cell is there. It is directly converted to bone, whereas endochondral, it is converted to cartilage, then bone. So there is problem in intramembranous ossification. So clavicle is membranous, ossified by membranous bone. So there is defect in clavicle, so it is replaced by the fibrous tissue. So there is abnormal intramembranous. So structures in the central skeleton are ossified by intramembranous system. So there is involvement of intramembranous ossification. It's an autosomal dominant, and treatment is just observation. This patient do well in their life. There is no need of worrying about the absence of clavicle. Though the only advantage is they can bring both shoulders together anteriorly. So this figure is also, a similar figure is also given in your practical DAS. So you need to remember it. It's a cleidocranial dysostosis. So I always tell to the patient that there is a few normal population, the clavicle is absent. That is in cleidocranial dysostosis, and they do well. So if the fracture goes into non-union also, it won't affect the patient performance so much. Then second condition is congenital pseudoarthrosis of clavicle. It is similar to that of congenital pseudoarthrosis of tibia. What is happening here is the medial end of the clavicle and lateral end of the clavicle are not fusing with each other during the embryonic development. So there is a fibrous tissue here. So it also present as a lump and little abnormal mobility. And these patients also, they do very well. There is no need of worrying. There is no need of any surgery. So here also observation is treatment. So considering these two diseases where there is complete absence of the clavicle and there is non-union at the clavicle since childhood, their performance is good. So even the clavicle is managed conservatively planned up in non-union or malunion, patient won't have much problem rather than patient who are developing complication after the fixation. So that call regarding the fixation or open reduction and fixation or surgery over the clavicle is very uh, it's depend on lot of factor like patient choice and the doctor choice and the associated complications. So our clavicle fracture should not be operated always. So with this, I end up my class today. So request you to share, like, and uh, subscribe to my channel.